Hi, everyone. I see people coming in now. We're going to start in just a few minutes, let more people come in on time. If you want, you can let us know in the chat where you're from. See lots of people joining. If you have a question that we don't address while we're talking or that you want to make sure we address, you can also stick that in the chat as well. We have some Beyond Celiac staffers that will be monitoring it and let us know if there's anything that we should be answering. If you are interested in research, you can always also sign up for our research news emails where you'll get the latest write-ups on what's coming out, anything related to celiac disease. There was some kind of exciting news recently, so sign up for that. I think Bailey can put in the chat a link to there you go. Thank you. All right, and it's 3 o'clock, so we can go ahead and get started. Thanks everyone for being here. My name is Maria Lucci. I'm the Director of Research Engagement at Beyond Celiac. Today's town hall is Therapies Beyond the Gluten-Free Diet, and it is sponsored by our friends at Immunogenics and their Solutions for Celiac study. You can learn more about their study for people with celiac disease, which Beyond Celiac is helping to recruit for at solutionsforceliac.com. You may qualify to be a participant in their trial. Today, I'd like to introduce our guest, Dr. Amelie Therrien. She's an adult gastroenterologist at the Celiac Center at Beth Israel Deaconess Medical Center and an instructor at Harvard Medical School. 50% of her time is spent on research, and recently she received a Junior Faculty Development Award from the American College of Gastroenterology. Her work includes mast cells and celiac disease in postpartum and clinical trials, including the Solutions for Celiac study on latiglutenase. Thank you for joining us. We had a lot of interest in this event, a lot of people signing up. And we are just going to dive right into some of the questions that we received. The first one, you recently published a really great article on non-dietary therapies for celiac disease, which of course there aren't any on the market yet, but there are a number in clinical trials. Why do you believe these type of therapies beyond the diet are needed?
Yes, so thank you so much for having me this afternoon or at lunchtime, depending on where you are joining from. So it was in fact a book chapter, mostly written by a fantastic colleague, Dr. Shakira Yusuf, and under the mentorship of Dan Leffler. First, I would like to say that people with celiac disease are incredibly resilient, finding ways to make the best of their new reality, which is to change not only their diet, but their way of living, forming communities to help each other, advocating for themselves, and trying to stay positive, although this reality may come with lots of frustrations. The general conception of people outside the celiac world is that a gluten-free diet is an adequate treatment for celiac disease. However, unless you are cooking all your meals, avoiding processed food, not eating at restaurants, and bringing your own food at social events, your diet may not be gluten-free all the time. To be continuously planning ahead what you are going to eat throughout the day, making sure that it is safe, be hungry because you do not find any sustaining gluten-free options is exhausting. You may be uncomfortable because your host who happily cooks something gluten-free use soy sauce that contain wheat. You do not want to be rude, but on the other hand, you're wondering if you're going to be sick. You go on a trip, did all your research about which restaurants can be gluten-free. You make a big detour to eat at that specific restaurants, but end up sick the day after, and it ruins part of your trip. So people do their best, but they may be exposed to variable amounts of gluten and may get symptoms from this. Other gets very sick as soon as they are exposed to gluten and have to miss work or important events. This may lead to hypervigilance and a very restrictive diet with only a few safe foods. So to have medications could improve quality of life, but also reassure people that they have something to protect their body if they are gluten, and ultimately, hopefully, be able to eat anything we want, any bagels or chocolate bread we want.
Yeah, we hear so almost every day someone's like, when can I eat a pizza again? Or
Yes.
a gluten pizza. And there are so many people that are so sensitive and they try so hard and then they're like, I'm just suffering all the time. So
Yes, and we know that the gluten-free pizza crust can be a big difference compared to the regular pizza crust. So it's a big life change.
yeah, I've heard people who don't have celiac disease say it's always the pizza. Why is it always the pizza? And I'm like, it's the big chain. It's a very different, you have to get used to it. It's not that it's bad, it's just that it's different and you have that nostalgia for the original flavor. But so can you tell us a little bit about your own experiences working in trials for therapies for celiac disease?
Yes, sure. So I started in 2018 at Beth Israel until the mentorship of Dr. Kelly, Dr. Leffer, Dr. Sylvester. Clinical trials are challenging in so many ways. First, you need to plan it well to maximize the likelihood that something will come out of it, meaning that even if a drug is not successful, even if the trial is stopped midway, it may still give us additional information on celiac disease, what happens to the body, to the blood when someone gets exposed to gluten in a controlled fashion. So as a participant, even if the trial is not successful with the drug, be assured that your participation still helped a lot in getting useful information. You also need to plan it in a way that is acceptable for participants, not to be exposed to too much gluten and get sick, not have study visits that are super long or too frequent, that it will jeopardize their work, not have too many invasive procedures. Then you talk and meet a lot of potential subjects and make sure that it is safe for them to participate in the trial, that their questions are answered. And we do end up discussing a lot about celiac disease, the optimal care, etc. And I've been present for most studies visits of all participants enrolled in clinical trials at Beth Israel since 2018. I have come to know them well, and it has come handy when the central team wants to get more context about a specific results or diary entry. I know all the participants. The research teams are trying to simplify as much as possible the participation. For instance, I am an investigator for Solution for Celiac, the latiglutenase enzyme study at Beth Israel. And the way the protocol is made, we are seeing participants only once every 5 to 6 weeks. So they get a very large tote bag with the enzyme or the placebo, flavor packets, snacks, urine collection kits. Every day at home, they take their enzymes. They have a snack once a week and they collect their urine and freeze it just after. And they feel symptom diary every night. So yes, every day they have something to do. At every meal, they have to take either the enzyme or the placebo, but they do not have to miss work or travel a lot for study visits. I am also amazed on how the celiac community wants to help out, and what is different for drug trials in celiac disease versus Crohn's disease, for instance, is that most of the time, to confirm that a drug is working well, participant must eat gluten and potentially get sick, versus Crohn's disease, where you are already sick and either get a drug that is working to improve you or not. So there are very few diseases where you need to expose the person to what causes the disease to test the drug. And the celiac community has been fantastic in participating in these trials.
Yeah, I always bring it up when I'm talking to people who work in clinical trials, like that this is such a unique disease to study in trials, where you're having to essentially make someone sick to see their reaction. And I also really liked how you brought up, even if a trial is canceled or the drug didn't perform the way that it thought it would perform, that you're still moving research forward, and that there will be deep dives into everything, and that oftentimes unique and exciting information comes out that's a little like what they thought was unrelated at some point. But that's a really good point. So you mentioned latiglutenase. That's like an enzyme type of therapy. What are some of the other techniques and therapies, or go more into the latiglutenase, that are currently under investigation, under in trials now?
Yes, so over the last 20 years, we have gained a lot of understanding about the pathophysiology of the disease, and then we are able to target different ways to protect the person, to avoid the activation of the immune system. So in addition to the latiglutenase, that is an enzyme that cut down the gluten in the stomach to remove the sequence that activate the immune system. And I just want to mention that recently there was a complete and published study performed at Mayo Clinic with that enzyme that showed that it degrades the gluten, prevents symptoms, and protects the mucosa from inflammation when people are exposed to 2 grams of gluten daily for 6 weeks, which is the equivalent of a slice of bread every day. But there is also another enzyme, TAC062, that is currently being studied, also with the goal to prevent symptoms and immune activation when people get inadvertently exposed to gluten. Another way to prevent immune activation is to block some of the arrows that the immune system produce in celiac disease. Arrows, I mean cytokines. So IL-15 is one of them. So PRV-015 is a subcutaneous medication that you get every 2 weeks. And the goal is that it will help people who get unexpectedly exposed to gluten in real life again. So this is another trial ongoing. There is a medication that blocks the enzyme transglutaminase. Everybody has that enzymes in their intestine. It changes the configuration of gluten. So for people with celiac disease, the immune system has lots of affinity with this new configuration of gluten. So blocking the enzyme may prevent immune activation. And there was a successful study last year about the TTG inhibitor. So it's a pill to take daily that will also help to prevent mucosal inflammation when people get exposed to gluten. There is another study that is underway for people that are still having symptoms despite their gluten-free diet, but it is in Europe. So all of these medications have the target to be kind of an adjunct to the gluten-free diet, to target people that have persistent symptom, that may have like low grade or inadvertent gluten exposures in real life. But we also have a medication that could help train the immune system to tolerate the gluten. So there is TAC101, that is a nanoparticle that is injected in the blood and travels to your liver and spleen and teach your immune system that gluten is not something to react to. So there was a first study that showed that it prevents immune activation when exposed to gluten. And there is a larger study that is currently underway in the US. And we also recently learned at DDW, which is a major digestive disease meeting this year, about CAN101, which has a similar mechanism of action and was also successful to dampen the immune activation caused by gluten and was safe for patients. So there are different options. Most of the drugs right now are for people that are still having symptoms despite the gluten-free diet. eventually we'll see if we can have medication that can replace the gluten-free diet.
Yeah, that was actually the next person was like, do you think we'll ever be able to eat breads and cakes and their quote, all the glorious products we have had to avoid?
Yeah, so this is definitely the hope. For now, most of the drugs that have had significant results were tested with 2 to 3 grams of gluten, which is the equivalent of 1.5 slices of bread. The tolerogenic particles, TAC101, CAN101, have been studied and are currently studied with intakes of 9 to 12 grams of gluten, which is substantially more, but only 3 days in a row. And these drugs are at an earlier stage of development, with studies looking at the optimal dosing of the drug, and time will tell if they prove to be protective and safe with repeated gluten exposures. But again, we have a far better understanding on how the disease works, how gluten activates the immune system. And so also we could eventually have some combination therapies to work on different pathway to have a better effect. So I think there is hope, but time will tell.
Someone actually asked a particular question about latiglutenase, and they wanted to know, and I don't know if you know the answer to this, but if it would help people with celiac disease who are also casein intolerant.
So both casein and gluten are proteins. Gluten is in cereals, and the casein is in the milk. It can be elsewhere, but in the question, I think it's in the milk. So they have similar amino acids. They activate the immune system in different ways, like casein is kind of an allergic reaction. But we currently have no data about the effects of latiglutenase on casein. There are nutraceutical enzymes that are commercially available, claiming to be effective against gluten and casein. But this has not been studied in celiac disease patients, meaning that even if there is some digestion of gluten, we do not know if they are effective in digesting the peptides that triggers the immune system in celiac disease. So those enzymes are not manufactured in a pharmaceutical GMP environment or approved by the FDA as a medication. So it is not recommended for people with celiac disease to take those commercially available enzymes and think that it will help them eat whatever they want.
Yeah, we actually posted an article a couple years ago about those over-the-counter enzymes and how they weren't safe for those with celiac disease. You kind of touched on this at one point, but what is the role of the gluten challenge in clinical trials? Why do we need one, and is it safe?
Yes. So if you want to make sure that a drug will inactivate the gluten or prevent immune activation, we need to expose people to that gluten during the trial. Some studies are in real life, meaning that we assume that people are being contaminated in their day-to-day life, and we look for the effect of the medication in that setting. But to know whether the drug will be effective to protect someone having a slice of bread or more, we need to test it with that amount of gluten. So the term gluten challenge is from an old established clinical procedures where you want to challenge the immune system to see if it reacts to gluten and makes a diagnosis of celiac disease. I would say that in clinical trials with people with known celiac disease, the gluten part in the trial is either a simulated accidental gluten exposure or a known calculated small exposure. So the intent is not necessarily to make you sick. It's just like to simulate like what will happen in real life if you get like the wrong cookie or the wrong crackers, and will the medication help you being protected? But I agree that it's not safe for everybody. Some people have very acute debilitating symptoms if they get exposed to gluten and cannot continue and keep being exposed during the trial. Other people are just being diagnosed and have significant inflammation, malabsorption. So we prefer that their mucosa heals before re-exposing them to gluten. We did a gluten challenge studies at Beth Israel and MGH where people were exposed to gluten for 2 weeks. There was a video capsule endoscopy before, immediately after, and 4 weeks after the end of the challenge. And people with the highest dose of gluten developed change in their intestines, but these changes were resolved after 4 weeks and in all subjects but one. So this is encouraging that there is a low risk of long-term consequences of getting gluten in a clinical trial setting.
And you made a good point, which reminded me that some of the trials were originally looking at how not giving you gluten because they expected you to be exposed slightly in your everyday life. But then when COVID hit, people weren't being exposed to gluten as much as they were because they're not going out, they're eating inside, they're preparing their own food, and the exposure was lower. So adding gluten was necessary in some of these.
Yes.
And I see in the chat somebody asked.
I didn't get that.
Oh,
Try again.
my watch is talking to me. I see in the chat someone asked about this too. Will children be able to get involved in clinical trials? Will therapies be available to children?
So I'm an adult gastroenterologist, so less in touch with the pediatric world. I do not do research with children, but I would say that in general, we first test the medications in adults, making sure it is safe and effective, and then apply it to children, usually with a lower dosing. In other chronic GI disorders, kids are eligible for therapies eventually if they are safe, but not to early stage clinical trials. And I believe that the struggles I previously mentioned about adhering to a perfect gluten-free diet certainly also apply to children with school, summer camp, going to a friend's house. To retrieve and maintain a normal intestine is very important for their growth, development. So all these arguments, these are all arguments to advocate for therapies for children once we have medication available and if the medications are safe.
Yeah, we've had a lot of kids interested and their parents coming to us asking when they can get involved. So that's always a question we have. On the other end of the spectrum, and I saw in the chat as well, again, somebody else asked, why do clinical trials often have an age limit of 70? They want to be involved, but they're over the age limit for a lot of the trials.
Yes, so this is not something unique for celiac disease. The elderly population is underrepresented in every clinical trials and every medical domain except for gerontology. This does not mean that people over the age of 70 years old will not be eligible to receive therapy. We usually either proceed with clinical trials in an adult population age less than 70 years old, and if the drug is approved, depending on the pharmacodynamic, either offer it to the elderly or proceed with additional clinical trials in their specific population. Phase 1 and phase 2 must be with the healthiest participants as it assesses safety, side effect. Older participants have more chances to have other comorbidities, medication, may have kidneys and liver that are more fragile, and some drugs are metabolized by the kidney, by the liver. So we want to make sure that we understand well all the pharmacodynamic of the drug, that it is safe in general, and then apply it to the way, the physiology, the way the body works for someone that is 70 years old and older. So this is why this population is often excluded from the early phase clinical trials.
That makes sense. There are other ways for people to get involved that are older or younger. You can donate, you can raise funds, there are certain studies that aren't clinical trials that sometimes take different populations as well. So there's still ways to get involved with research. I saw someone else asking about that.
Yes.
What therapy is currently the most advanced in the clinical trial phase? Do you know?
So currently the most advanced trials in the United States are the latiglutenase, the enzyme solution for celiac study, and PRV-015, the proactive celiac studies that are both phase 2B, meaning that the drug has already undergone phase 2 trials, and the trials are looking for effectiveness and safety in a particular setting, which is people who are still having symptoms despite following a gluten-free diet. There was a drug in phase 3 trials, larazotide, but unfortunately, the trial halted early this summer.
Yeah, and one of the reasons they gave was that they're not enough, they just didn't have enough people, they needed a lot of people. And so that's another, we need everybody who can, who doesn't get too crazy sick with gluten, who's in the right age group. If you are willing to, please join a trial. Let's see, someone else asked, are any trials looking into therapeutics and their effect on the neurological symptoms of celiac disease, or are you just looking at GI symptoms?
To my knowledge, there is no clinical trials for therapeutics targeting specifically neurological manifestations. So there are different neurological symptoms in celiac disease. It can be migraines, brain fog, neuropathy. Some people have ataxia, but this is a separate gluten-related disorder than the common celiac disease. The mechanism for these neurological signs and symptoms are not well understood. And in general, these manifestations are not the main outcome in clinical trials. And for instance, headache may be a drug side effect, so it is hard to interpret. I think that we'll have to wait for large phase 3 or 4 studies to see if in a subgroup of people with baseline neurological symptoms, these improve. There is also a team in the UK that specializes in neurological manifestations of celiac disease. And if there is eventually a study about a treatment for neurological manifestations, it will likely come from them. Other than neurological symptoms like tiredness, fatigue is a clinical endpoint for some of the trials in celiac disease. So we can see if the drug has some effect on specifically the tiredness and the fatigue. But again, for the neurological symptoms, we'll have to wait.
Well, and you mentioned, and I just want to give a little shout out to our friends at the University of Sheffield in the UK, who we are funding their study into the effects of gluten on the brain. So I think someone can put in the chat from Beyond Celiac more info on that. So stepping away from treatment for a moment, somebody asked, are there any advances in diagnosing celiac disease, especially around the gluten challenge?
So yes, one of the benefits of the NextVax2 trial, which is the vaccine trial that stopped in 2019, because yes, on one end, the primary endpoint in the interim analysis was not statistically significant, but they discovered that the immune system of people with celiac disease released the cytokine, like the little arrow, IL-2, that very rapidly at the time of gluten exposure. And this is measurable in the blood. And they further realized that if you take the blood of someone with celiac disease and put it in contact with gluten, the white blood cells will release IL-2. And this happens even if the person is following a gluten-free diet. So further studies are needed to see if it is reliable in clinical practice. But this may be a way to do a gluten challenge on your blood and not have to ingest gluten if you already started a gluten-free diet before having a formal diagnosis. So this is one example of a side benefit that we got from a very big drug trial that unfortunately was stopped midway.
That's awesome. I knew that about the cytokine thing, and the gluten challenge might be shortened or might not even be needed, but I did not know that information had come out of the NextVax trial. So that's really interesting. I know a lot, it would be a huge deal if we could even shorten the gluten challenge, and because we know so many people who are like, I'm not going to go back on gluten to get diagnosed. I can't handle the amount of time. So that's exciting. We'll be following along with that. Someone else asked, they saw you worked in mast cells. They have both celiac and mast cell activation syndrome. They would love to hear more about anything that would be helpful in managing both, or maybe will potential therapies help both, or are those two very separate things?
So mast cells activation syndrome is so difficult to deal with and unpredictable. I'm very interested in mast cells and celiac disease and whether mast cells could contribute to some symptoms. Some people with celiac disease present with diarrhea, while others have mostly extraintestinal, like neurological manifestations, like we were saying. In addition to the mast cell activation syndrome, there is a new condition called hereditary alpha-tryptophanemia, where the mast cells have more copies of the genes that produce tryptase. So they release more of that enzyme. And we also know that mast cells, when stimulated in vitro with gluten, are releasing histamine. So we are looking into whether to have hereditary alpha-tryptophanemia modifies the phenotypes of celiac disease. And if this is conclusive, we could hypothesize that some drugs that are mast cell stabilizer could help in some people with celiac disease, depending on what are their symptoms. However, time will tell if all the therapies we discussed previously for celiac disease will prevent mast cell activation. The therapies I previously mentioned either like prevent the gluten from like accessing the intestine and activating the immune system, or have other specific targets on the immune system. So we will see.
What are, for people who don't know, what is mast cell activation system and what are some of the symptoms?
Yes, so there are different things like mast cell activation syndrome is to have mast cells. First of all, mast cells are cells in the immune systems that are filled with little granules, and they are involved in like allergy reactions. So, and they get stimulated by, at first, an allergen if you're allergic to peanuts or to bees, for instance. But there are other people that have mast cells that get activated by lots of other stimuli, like it can be cold, it can be like random foods that when the sequence are attaching to their envelope, to their receptors, they kind of like burst and release lots of their little granules. And that causes a surge in histamine, a surge in other mediators, and people can get flush, can get hives, can get diarrhea, hypertension. So it's kind of like a major like allergic reactions that again can be unpredictable because sometimes they are reacting to any stimuli. Sometimes it's even stress that can lead to activation of their mast cells. Hereditary alpha-tryptophanemia is at first a genetic trait, so it's to have more of a gene. And some people are like that, and it's fine; they don't get any symptoms. But other people have hereditary alpha-tryptophanemia syndrome, meaning that they get some symptoms from that. So they also get some itchiness, some hives. They can get some non-specific GI symptoms like bloating, diarrhea that we cannot explain, and we put that on the side of like IBS. But we realized that up to 5% of the US and British population can be carrying that trait. So some people with like non-specific unexplained symptoms may have a condition affecting their mast cells.
Thank you. That's really interesting. I've heard a lot more people lately talking about mast cells and mast cell inactivation syndrome. There's a question I accidentally skipped. What is the long-term prognosis regarding potential permanent intestinal damage, post-remission? And I saw someone else in the chat talking about damage when you're symptom-free, like that's really difficult. You don't know if you're getting damage, and then it's hard to stick to the diet. And so what's going on with the damage, and what's the long-term prognosis?
Yes, so I would say that every intestine and immune system is different, and people may have low-grade exposure of gluten, and the time it takes to normalize the intestine is highly variable, even if the person is doing his best on a gluten-free diet. The older you are, the longer it may take to your intestines to heal, and children tend to do better in terms of rate of mucosal recovery on a gluten-free diet than adults. There is a population study from 2013 from New York, Ben Lebuel and Joan Ludvigsen, that showed that persistent villus atrophy in treated celiac disease patients, so on a gluten-free diet, was not linked to an increased risk of mortality, neither in adults nor children. So in general, the major complications are among people not following a gluten-free diet. But when I say not following a gluten-free diet, I say not adherent at all. Like let's take outside like the little cross-contamination. We also know that despite retrieving a normal architecture, there could be some specific lymphocytes that stay in the epithelium forever after a diagnosis of celiac disease. But the risk of developing a lymphoma or refractory celiac disease from these lymphocytes is low, and there are likely other genetic factors at play. So for the persons who are asymptomatic and are concerned, first, although it's not a perfect marker, like to have serial TTG, DGP, like the regular celiac antibodies, testing are good because if elevated, it's more clear that they are exposed to gluten. Although this antibody is not like super sensitive for little sporadic gluten exposure. The other thing they can do is get some gluten immunogenic peptides testing kits. There is on the market either urine or stool test that you can do, and you can see if for the stools it can be over the spectrum of a week whether or not you have been exposed to gluten. The urine, it's kind of like the last 16 hours before. So we know that to have like persistent like gluten in the urine and the stools was associated with persisting villus atrophy. And then, yes, you can repeat the biopsies with your gastroenterologist. If the mucosa is improving, it's still good news because again, even if the person is following the gluten-free diet the best they can, at least 43% of people at 2 years did not have normal biopsies, and the biopsies are not perfect. Like the biopsies are only sampling like a small part of the small intestine, and the disease can be patchy. But overall, following the gluten-free diet the best you can, there was no increased mortality in the cohort that was still having some villus atrophy. So that was still encouraging in terms of like cancer risk and mortality risk. The important thing is to avoid gluten as much as possible, to not have activation of your immune system.
Thank you. Somebody in the chat asks, are those with celiac disease that are asymptomatic, the silent celiac, able to participate in research studies? They're biopsy confirmed, but they don't have ongoing symptoms.
Yes, so we have different types of studies. I mentioned some studies that had that were targeting people with persisting symptoms despite the gluten-free diet, but the people with no symptoms are very good candidates for the phase 1, phase 2 trials with medication that we want to see. Are they working in preventing gluten absorption, gluten activation from the immune system? So these people may tolerate better a gluten challenge during I say gluten challenge, but gluten exposure during the study. And then we can see if the drug works well on the immune system. So these people are definitely good candidates for clinical trials.
You mentioned we have been calling it gluten challenge, but a lot of the studies it's not the same amount of gluten you would ingest versus a diagnostic gluten challenge. For a lot of them, it's a lot less than in at least some of, I know in the latiglutenase, it's not like, I know some of the gluten challenges, they make you eat a lot of gluten every day for a long period of time. So it's not, though using the terminology gluten challenge, even though that's what people understand it to be, it's a spectrum of amount of gluten that you're going to ingest.
Yes, it's a spectrum. Like studies that are giving like 10 grams of gluten or 12 grams of gluten per day, that is like 5 or 6 slices of bread. So this is like almost the equivalent of like a day of gluten, although usually in the general population, it's more than that. So most studies have lower amount of gluten, but that mostly target like what will happen if in a restaurant or at a friend's house you get like something that was not right. And for clinical practice, we want to make a diagnosis. We don't want the person to undergo that and then have unconclusive biopsies. So as much gluten as they can take to then have eventually their blood work and their biopsies, the better it is. We know that in general, 2 slices of bread for clinical practice can be enough, but it may have to be up to 6 weeks of having that every day. And lots of my patients do not tolerate that well.
Yeah, that's a good point. I know you don't have a crystal ball, but a lot of people are asking, when can we realistically think there might be a treatment on the market?
Yeah, so I know that every time people are saying like 5-10 years, it's encouraging that we have studies and drugs that are in phase 2B. We had one that was phase 3 up to last summer. So this was not the case like 5 years ago or 10 years ago. So this is all very, very encouraging. And the FDA is putting some attention towards like the research and the drug developments in celiac disease, although this was a bit controversial last summer with their like guidance, etc. But there's lots of like interest from the pharmaceutical industry that was not necessarily the case in 5-10 years ago. So I think there's good hope that in the next 10 years, there will be something.
We hope so too. We hope. Someone asked if these drugs could help with other autoimmune diseases, because I know like for like lupus and Sjogren's and RA, there's several drugs that work across those. Would celiac disease medications work for anything other than celiac disease?
Yeah, so it depends on the mechanism of the drug. So enzymes maybe could work on other intolerance, other proteins intolerance, although I mentioned that we do not know for latiglutenase and casein. For the TTG inhibitor, I know that it is currently being studied in non-alcoholic fatty liver disease because we have TTG also in the liver, so that medication can work in some liver disease. The tolerogenic nanoparticles like TAC 101, that model is a vehicle that brings any peptides, any molecule to the immune system in the liver and in the spleen. So I know that there is also some developments in other types of autoimmune disease with that medication to kind of like try to train the immune system to tolerate other antigens. But it will obviously not be the same drug as TAC 101 that contains like gliadin peptides, but that type of like technology can be useful in other autoimmune diseases.
Sorry, I've had a cold.
The cough is coming back.
So is there anything else that you would like to add? Any research or anything that you found interesting that we haven't talked about? Or
yes, I would like to say that we have an international celiac disease conference in Sorrento next month in October. So that will be very exciting, and we will certainly learn more especially from our Europeans, Australian colleagues. I would like to thank all the study participants for their time and devotion for participating in clinical trials in celiac disease. The study teams are doing their best to facilitate their participation. But I know that the participants are being very helpful and very flexible.
Yes, we thank you to everyone who has participated in any study, trial, donated to research, everybody who's in our community. We will also be at Sorrento. I will not, unfortunately, be in Italy, but Beyond Celiac is presenting 2 pieces of research that we're very excited about. And someone asked, one more question that someone said, please, for refractory celiac disease, are there any drugs on currently in trials, or will people be able to, will they help with refractory celiac disease?
Yes, so this is one thing that I'm very happy to go to Sorrento for. So there are 2 types of refractory celiac disease. Like there's the type 1 and the type 2. We do believe that what was put into the category of like type 1 refractory celiac disease is either like still having some low-grade gluten exposures, or having an immune system that is a little bit more like reactive, that does not shut down. But these people do not have a risk to transform into a lymphoma. The type 2 refractory celiac disease do have abnormal genes, abnormal lymphocytes, and they are more at risk of progressing into some complications. So there is the Europeans have a big consortium where they are following these patients, and I found that there are specific genes that could be at play in those people that develops refractory type 2. And they have tested some JAK inhibitors. They have tested some, in fact, multiple myeloma medications with some success, like in vitro, like in the lab on the cells. So I think that there will be a more positive development on that, because I know how deadly that disease is, and how the current therapies, especially like having a stem cell transplant, also have a major load of complications. So I do believe that there will be additional therapy soon, but it is a very, very rare disease. And it's better to be followed at a very expert celiac center in the United States if someone in the audience has that disease.
One of our former board members has refractory celiac disease, and it's been quite a challenge. I'm going to wrap up with somebody asked, what words of encouragement can you offer while people are waiting for a treatment?
Yes. So it's to compare. How can I say? I know that it's hard. It's hard to stand for yourself, especially at like social events. It's hard to feel hungry when there is no gluten-free options. But overall, it can make you discover something new in you, some strength that you did not feel that you were having before. It can gives you additional community, additional friends. The celiac community has been so great to have like networks in every towns, every state, every country, where people are helping each others. And it's to advocate as much as possible for yourself in restaurants, in with the food industry, and also with friends and colleagues, and explain your situation. But I know how hard and difficult it can be.
Yes, and we hear from all ends of the spectrum, people who are, I'm fine going gluten-free, I like this lifestyle, I eat healthier now, and other people who are really struggling. And I think it's really good to get people together and talk about the shared experience, and especially children who have, we hear so sad, you know, feeling left out, like finding someone else who is similar to you can really have a big boost of effects. So we see a lot of people, if you want to follow us on our social media channels, every Sunday night we have a best gluten-free finds, which people seem to really love, and just sharing your experiences. We have a Voices of Celiac project, which someone maybe can put a link to in the chat, where people share their stories, and it seems somewhat of a cathartic experience for people. But I wanted to thank you so much, Dr. Therrien, for joining us today, and for our sponsor, Immunogenic and Solutions for Celiac. If anyone is interested in learning more about Solutions for Celiac, you can visit solutionsforceliac.com to learn more about their trial. And as some people had asked, yes, this is going to be recorded, and we will post it online, and we sent out an email to everybody who registered with a link. And thank you so much again, Amelie, for joining us. We loved having you, and we hope to have you back sometime.
Yes, thank you so much for having me. This was super fun.
Yeah. All right. Bye-bye, everybody.